All right, on to the next slide set. This is another hospitalized patient presenting with these pink, kind of eroded, scaly patches in the bilateral chest area and axilla. And this is one I do want you to know. This is one that you can't really go down the morphologic pathways as well in terms of epidermal dermal. This is one I think that goes more through Gestalt, having seen it before. So when you have this reddish brown discoloration with this eroded appearance, you really want to think about a couple things. Not a lot looks like this. The first thing that comes to my mind when I look at this is nutritional deficiency. So erosions, scale encrusting, this kind of reddish brown color, really nutritional deficiency should come top of mind. And the second thing is that one of the things that we already discussed in an earlier case, it's going to be like a toxic insult. So you can see that this is appearing to favor this patient's axillae and inner chest where there's a lot of eccrine glands again. So again, you can think about some type of toxic insult to this area. So is this a chemotherapy patient, a cytotoxic chemotherapy that's being just excreted and causing erosions? Or is this a patient who has methotrexate toxicity who's having the same findings? And this actually was a methotrexate-induced rash here. This is a patient who was on methotrexate for years for RA. She had stopped it for a while, then restarted it at too high of a dose in the setting of now having bad kidneys, and she developed methotrexate toxicity. But the key is when you see erosions and breakdown of the skin like this, you think about toxic, either toxic because you're starving the skin of nutrients from nutritional deficiency, or toxic because there's chemotherapy or methotrexate metabolites directly hurting the skin. This is a nail case, which I think are fun. Again, like I mentioned before, we do skin, but we also do hair, nails, and mucosa. So what are we seeing here? We're looking at a thumb. We see that the thumb looks dystrophic because there's a growth here appearing in the nail bed, in the proximal nail bed. So just, reviewing anatomy, I won't go through it all completely, but you have to know your anatomy pretty cold to know what's going on with nail diseases. But if you reflex the proximal nail folds, this is where your proximal nail matrix is, and it comes out as your distal nail matrix and is seen through the nail plate as your lunula. So this is a nail bed abnormality, probably somewhere at the junction between the proximal and distal nail matrix. This is a broad differential diagnosis. You're not going to look at it and say this is what it is, but there's a few, nail tumors that we think about. When you look at this, you think about a glomus tumor or its cousin glomangioma, any other type of vascular growth. You can get angiomas in here. You have some type of other matrical tumors like onychomatricomas and onychopapillomas. Those are usually going to cause more distal nail changes and or longitudinal erythronychia. Squamous cell, verruca vulgaris, things like that have been described as well, and this was a glomus tumor. This is a cool case seen on consults, patient with darker skin type presenting with diffuse kind of pink to purple brown plaques on her skin. And here's one I think, unless you're just a complete rock star, which could happen, it's going to be hard to look at this and say this is X, Y, or Z. So this is one where I think it is really helpful to put in a bucket. Is it epidermal, dermal, and then what is it from there? Here, this one's clearly epidermal, right? You can see that all these plaques are raised up from the skin. They have a lot of scale. So once you're in the epidermal, you think about, is this papulosquamous? Is it eczematous? Is this a pigmented disease? Is this a vascular disease? Here, I think we'd all agree this is papulosquamous, meaning bumpy and red. And then once you're in papulosquamous, all of a sudden you can throw out things that it might actually be. Is this psoriasis, parapsoriasis, CTCL, tinea, lichen planus, probably a bunch of other things I can't remember on the spot, like PRP, things like that. And this was actually lichen planus, which I thought was interesting because this is not exactly what I would go to here. We think about our classic purple polygonal fat top papules on the flexor wrist, but this was a kind of a diffuse, more eruptive form of lichen planus. So I think this is a good example of getting yourself in that bucket and generating a differential diagnosis. This is the next case, really classic. Nothing else looks like this. So you're looking at the posterior back near the scapula, and you have a well-demarcated oval hyperpigmented patch, and this is macular amyloidosis or notalgia paresthetica. Pathophysiologically, it makes sense. All these nerves that are coming out the spine are getting pinched. It causes irritation. The person's rubbing or scraping it. It breaks keratin. The keratin falls in the dermis. It gets chewed up and it looks brown.